All right. Good afternoon, everyone. I know that we had lunch, and please keep awake for this talk, because I think you will be able to see what the future, near future, is bringing to us. So I'm going to talk to you about something that is very dear to us as the heart hospital, structural heart disease. And it has evolved very rapidly over the last decade as a subspecialty of interventional cardiology, and now we call ourselves as structural heart interventionalists. That is truly what we do. We treat patients. You have seen surgeries, open heart earlier today. We treat them through the catheter-based techniques in patients who had congenital heart, as well as we get older, acquired valvular heart disease. However, that requires that to have this technology at our hospital or other hospitals requires a multidisciplinary team that composed of many members. CT surgeons, you have seen me working with interventionalists, cardiac imaging folks, and coordinators. So bottom line is it requires significant amount of time, administrative time, and also a lot of administrative support financially from the hospital administration as well. So we are lucky to be one of the leading centers in structural heart interventions in the United States. So this graph just summarizes, tip of the iceberg, what areas of development are being done at the moment in regards to structural heart disease. Earlier today, you have seen that we have closed very nicely catheter-based technique, the left atrial appendage on a patient who cannot take oral anticoagulation. We have MitraClip. We have transcatheter aortic valve implantation. And believe it or not, we have percutaneous left ventricular assist devices already. So for these techniques to be sustained and to be taken by the patients and to be accepted as cutting-edge medical care, they have to have comparable safety and efficacy compared to open heart surgical techniques. They have to have similar or significantly less both short and long-term mortality and morbidity, similar long-term outcomes and durability, similar or lower procedural costs so that a hospital can adapt these techniques and the CMS, and similar or less procedural associated complications. It has been, as of today, 15 years since the first patient in France, Rouen, has received the transcatheter aortic valve implantation with this pioneer, Dr. Alain Carabier, under moderate conscious sedation, no intubation. So it has been absolutely 15 years. We are very excited about that. We all know some of you may have been involved in the care of transcatheter aortic valve implantation patients. Now this is daily routine. So we have at the moment two commercially available devices in US. One is Evolute by Medtronic. The other one is Sapien 3 valve by the Edwards Life Sciences. And those are the current valves that we are using at the moment. However, there is a lot on the pipeline. But what we are treating is really truly the tip of the iceberg. Even in the high-risk population, we recently visited California. We can see from the CMS data based on echo, those patients who are high risk, they are just not being treated. 30% of patients who are high risk, they are not necessarily being referred to the centers to be treated. But now the study is more than 30,000 patients in intermediate risk. Low-risk studies are ongoing. This is definitely moving on. So the CMS, Medicare, as well as the SDS projects that in the next few years, the TAVR volume in the United States is going to be quadruple. And how this is going to happen? We will have prosthetic valve failures. It may be surgical, but they fail. The surgeon doesn't want to open up them again because of high risk. Then they have basically low flow, low AS patients. Bicuspid trial is now going on, we learned from Medtronic for bicuspid patients. And now there are investigator-initiated studies in patients who have multiple valvular disease like MR and MS. They are being treated in the same session. They have TAVR and they have MitraClip on the same session. Moderate AS patients are being treated under the UNLOAD trial. So you don't want your LV to go into scarring and fibrosis. You want to treat it early so that that patient can get benefit of the valve treatment before they have irreversible LV damage. So the time, believe it or not, has arrived for a fully repositionable, retrievable valve, so that we do this procedure even safer now. So the Lotus valve made a big headline. This valve is a self-expanding valve, nitinol, and it has an adaptive seal on it. We can adjust the depth, and the technology is being now developed even more. They have a depth guard now. The critiques have been the high rate of pacemaker implantation rate, around 20% or so. However, because of the depth guard, because of the way the valve now is going to be deployed from upper rather than the lower, and we will be able to control the LVO2 pressure, the rate of the pacemaker is going to go down. When you look at in this busy graph to the bottom line, moderate to greater PVL, it is negligible as compared to the core valve, 0.9% versus 6.9%. We want to achieve absolutely similar results with the catheter-based techniques in certain subset of patients compared to the open heart valve replacement for these techniques to be sustained. Recently, I have been in Zurich and basically involved in some of this technology development. So from now on, instead of as we putting these valves in and we worry about if they are going to last long, tissue fixation has been an issue. From now on, we are able to synthesize your own valve from your own cells, not from embryo, from your own cells. So we use a bioabsorbable scaffold to put the cells on, and this valve is generated under the milieu of the serum, your own valve. This is in a ship's model that has been implanted on a nitinol frame, and the bioabsorbable scaffold completely reabsorbs, and then what you left it with your natural valve, so that the degeneration does not happen. The Columbia is going after this valve right now. The second thing is that what we have is now we are doing real good job in regards to vascular complications because devices are small caliber. We are doing good job in regard to most of the cases are transfemoral, but even though it is less than 1%, some patients do have stroke, and stroke is a big deal. You don't want to replace someone's valve and they end up with stroke. So we have developed devices that will protect both carotids and prevent embolization to cerebral circulation. That is not going to be used in every single patient because just placing the device can put you at risk as carotid stenting. But in certain subset of patients who had prior stroke, who have huge mobile plaque in the aortic arch, etc., we may have to use these devices to prevent stroke. Now switch the gears to the mitral valve. Mitral valve is even more forbidden than the aortic valve. Only 2% of the population that requires the treatment is currently being treated surgically. It is the tip of the iceberg because they are not referred to the centers. They keep sustaining on the medical therapy or CRT, but some of them do not respond. Now we have as well in our center, we are the only center doing the MitraClip. More than 45,000 patients are treated in the world and 96% success rate. And most of them are functional outside the United States because the leaflets are normal. You can grab them easily. And surgeons don't want to operate on those patients necessarily. But in the United States, it's restricted to DMR, degenerative valve, meaning that the valve is falling apart. So this is the STS database and TVT registry. So most of them are degenerative MR. However, some functional MR patients have been treated under commercial and some are mixed. So if you put them together, around 16% of the cases have been the mixed FMR and mixed pathology. So number of the MitraClips that are being deployed in the United States or patients have been treated is steadily on the rise. This is the future for high-risk patients. Their intermediate risk study is going to be started soon. Most of the time, the patient leaves the lab with less than 2+ MR, 92% of the cases without significant MS, and the results are sustainable up to 5 years. It is shown very clearly. So what do we do with MitraClip? We basically switch these patients from MIHA functional class 4 and 3 down to 1 and 2. Do we care about that? Absolutely. I mean, some people may critique us and say, well, they still have congestive heart failure. Well, if they are not being hospitalized, repeated to the hospital, that saves money to the hospital, patient is no longer in the hospital, and indeed, we know patients who have resumed their regular activity as compared to before treatment. The COAP trial has been completed. Congratulations to Abbott, and it is 610 patients, and the results should be released, I suspect, that in TCT, and it is going to be up to 5 years follow-up in patients with heart failure, functional MR, meaning their leaflets are normal. And what I think is going to show is reduction in hospitalization, no mortality benefit because the sample size is small. How do we know that? Because from Everest study, as you can see down there, functional MR does really good after the clip. The new technology is imitating the clip through the Alfieri procedure, creating a double orifice, is called FSCAI. And that is basically purchased by Edward Life Sciences. It imitates the clip, but the only thing is that you can grab one leaflet at a time. And I don't know if you know the personality or read the personality of Pascal, but he was a miserable guy inside, but outside he was the most happiest man in the face of earth that you can meet. That's what they say about him. I read a little bit about him. And the procedure is done, the Edwards Pascal mitral valve repair system is done through the transeptal that we showed you earlier, the transeptal puncture. We basically bring the spacer where this is one of the cases that has been done in Europe. And you can see in the 3D beautifully on the left side, we are dipping down into the mitral leaflet, the arms are open, and you can see the flail right there that we are grabbing basically one leaflet at a time. The studies are going to be started in the US. I am hoping that we will be one of the sites, hopefully. And the other technology that was basically made big headlines in Europe PCR is called CardioBand. Can I imitate how Dr. Williams does his mitral ring in the OR through the catheter-based procedure? Well, here is the transeptal puncture. We come in. We bring the device that creates basic application under the 3D TEE guidance and fluoroscopic guidance in the real time. We can really see, we take our time, we know how to navigate inside the heart in 3D dimension, and we go, we basically come to the base of the commissures, and then after that we start putting our, if you want to say, pledges or sutures, with screws, if you want to say, and then we basically bring the streak. Jason, can you drag the video a little bit, please? And then we go around the annulus. We deploy this device. And then we come to the base. Jason, drag it a little bit, please. And then we basically pull the string back. We narrow the orifice. We bring a cutting system and cut and leave that. So how does the result so far? In Europe, this is CE approved. In the United States, trials will be started. And this is 91%. Most of the patients leave the cath lab with MR reduction less than 2%. So this is very promising. The other one that I was involved in early stages when I was in the University of Maryland is called NeoCord. So we said if the reason for the mitral regurgitation is LV dilates and the alignment of all this subvalvular apparatus changes, why don't we try to make a new one to realign and prevent without damaging the leaflet, we create a new cord. So that is called a NeoCord system. We will be working with our CT surgeons as we did in the transapical tower. We will go from the apex, identify the 6th intercostal space. The surgeon will do that. He will puncture the apex, and we will go in. My grandma used to do some cross stitching, so you will see that we will go in there. Jason, drag it a little bit. We identify where the flail segment is, and here comes, we grab it, we bring it down at the tip of the leaflet, this one. We basically then cut it after pulling through the length we like it. Jason, drag it, please. And then come to the apex and cut suture. And leave that. So let me show you a case that is done in Europe. And this is, you can see it is like Barlow disease, meaning the leaflets are quite redundant. You see the MR jet basically right at the leaflets. And this is after repair. There is now significant residual MR in 3D. And you can see that leaflets are opposed well with each other. This is called harpoon device, similar to the tendine technique. And we go, this time we grab it at the base. And we put our suture. We come back to the apex. And we cut. This study, this device is, and you can see a case that we have done in Europe. That's right there on the left side. And then we put our device. There is no significant residual MR right after as soon as we do. So the NeoCort is CE approved. It is being purchased by the companies in the United States, I'm sure. The Harpoon device is purchased by Edward Life Sciences. We are very lucky to have, in certain patients who have a little bit of MS, a little bit of MR, more MR, we cannot do clip because we create a mess. So on those patients, we are lucky to be one of the a few centers in the United States, a technique called Tendyne, percutaneous mitral valve replacement. So we go with a Fogarty catheter. Surgeons know that. They do thrombectomy. We want to make sure that our path is clean because we are going to bring the device after doing transapical puncture. We bring the device. It is self-expanding nitinol, PTFE. Under fluoroscopy, we have our marker. Very carefully, we deploy the device, which is fully repositionable and retrievable even after 5 days. And we bring it, we deploy it. Now the two-leaflet double orifice valve, two-leaflet valve change into three-leaflet valve. We bring it back. We create a Tendyne there, if you want to say, or Cordy, and then we plug it up. Jason, drag it a little bit, please. And then we will come out. And then we plug the apex. It is 32 French. And the next technique is called mitral in technique. So we go from the IJ. This is for the tricuspid. Tricuspid is a forbidden valve. There is like a forgotten valve. It is like a 1.2 million TR patients. They are not being treated. So we go in, we imitating the surgeon's pledged technique. We come from the IJ, and then we go under the leaflets, under the annulus. We start putting sutures there or pledgets like the surgeon do. We bring another sheet. We come down. We do this under 3D TEE guidance. Jason, drag it, please. We put our pledget down. Drag it, please. Drag it, please. Drag it. Drag it. Drag it. Drag it. Drag it. And we oppose them together. So basically what we do is we create a single orifice two-leaflet valve. Next picture. Next one is called spacer. That basically redirects the TR jet flow. Studies are going, and we have a dedicated tricuspid percutaneous valve studies. The early studies, SHIP studies are ongoing at the moment. So the next thing is you have seen, this is a clot just waiting to go to the brain, the large mobile mass. So you have seen earlier we did Watchman. We are lucky, thank you to Dr. Murphy and our research team. We will be one of the leading institutions in regards to enrollment. I believe we already have 4 patients. This is called Amulet device. This is by Abbott, St. Jude. So it has double lobes, if you want to say, one lobe and then one plane. Can you move forward, please, Jason? So we come the same way we did this morning, the same way. And then we deploy very carefully the first portion of the device. That goes deep in a little bit. And then we pull back a little bit more, very steady. Don't push anything forward. And then we patch it up. So we will be one of these centers as well. And the next one is, this is big. This is going to be really big. This is for patients who have diastolic heart failure. So why do we treat them with fluid medication? Everyone knows that, even layman on the street. So you get congestive heart failure, you get fluid medication, right? Because your left atrial pressure is high. How do you decompress that? You give fluid medication. Well, if you decompress the LA to the RA in patients who have no significant pulmonary pressure elevation through a small hole, that controlled iatrogenic hole, that you make it intentionally to decompress the LA. This is the device. It's a self-expanding nitinol. It creates a shunt of 1.2 to 1.3. And remember, this patient is usually around 40 plus years old. So they most likely will not live long enough to develop significant pulmonary hypertension. And this is after the deployment. And another device is called, by the Israeli company, is called V-Valve. Corvia device, as I said. Jason, drag it, please. Congestive heart failure situation again. Look at the flows. Jason, drag it. Drag more. So this goes to device. Drag it more, Jason. Drag it more. We will do transeptal. We go from right side of the heart to the left side of the heart. We became a true expert on that. Go ahead, Jason. Move it forward, please. And then we go in with the sheet, 14 French. We deploy the device. Move it forward, please, Jason. Okay, and we decompress. So these patients, early studies have been done, and these patients have been free of taking diuretic. You don't have to worry about their potassium. That is going to be big. Now, for all these tools to come to our patients, you need a hospital, like the heart hospital. The administration, and we thank our administration. Day and night they work to try to bring down the prices and make it affordable for us to use this. I really mean it. That you need a hospital with a vision, which we have. We need a team with a vision, which we have. We have a fantastic structural team. And this patient had TAVR in the morning, 7 a.m. I usually take them and amuse them a little bit. And then she comes into the cath lab to thank the folks around noontime. And we have great patients. This is a 93-year-old retired nurse. And she kind of felt a little bit uneasy after the procedure. I said, I don't know how I feel. I said, okay, I get you something. It was Red Nose Day. I get you Red Nose, one for you, one for me. And we have very powerful guys in our cath lab. They not only do the job well, but I show you their muscles good. And our patient, by the way, go back to that 93-year-old patient. No sedation. She said, I don't want any sedation. She's smiling. She's not crying. So she was really happy. I take them sometimes to lunch, or patients. So she had TAVR this morning, and then we took her to the lunch. They do leave. You may believe, 92-year-old, are you crazy doing these procedures, your team? No, we are not crazy. They leave the hospital, and some of them basically go to cardiac rehab, most of them, and they are fully functional. And they appreciate what we do for them. And for that, I thank you.